The United States spends about $12,000 per person on healthcare every year. That includes what you pay directly, what your employer pays for insurance, what the government spends on Medicare and Medicaid, all of it combined, $12,000 per person. Meanwhile, Canada spends about $5,500 per person. The UK spends about $5,000. Germany spends about $6,500. France spends about $5,500. These countries with comparable quality of care and similar life expectancies spend half or less than half of what America spends. And here's the fascinating part. Despite spending more than twice as much, the U.S. doesn't have better health outcomes. Life expectancy is actually lower, infant mortality is higher, and many health metrics are worse. Today, I'm going to walk you through exactly where that extra $6,000 per person goes, why the American healthcare system operates so differently, and what this means for your wallet. Let's start by breaking down what $12,000 per person actually means in practical terms. For a family of 4, that's $48,000 per year in total healthcare spending. Now, you're probably thinking, I don't pay $48,000 for healthcare. And you're right, because this number includes multiple sources of payment. It includes your insurance premiums, whether you buy them yourself or your employer pays them. It includes your deductibles, copays, and out-of-pocket costs. It includes what the government spends on Medicare for elderly people and Medicaid for low-income people. It includes what employers contribute to employee health plans. When you add all these sources together across the entire population, it averages out to about $12,000 per person per year. In comparison, let's look at other developed countries. Canada has a single-payer system, where the government is essentially the insurance company. They spend about $5,500 per person. The UK has the National Health Service, which is fully government-run, and they spend about $5,000 per person. Germany has a multi-payer system somewhat similar to the U.S., but heavily regulated, and they spend about $6,500 per person. These aren't poor countries with limited health care. These are wealthy, developed nations with modern hospitals, advanced medical technology, and well-trained doctors. In many health outcome measures, life expectancy, infant mortality, chronic disease management, they perform as well or better than the United States. So the question becomes, where does the extra $6,000 per person in the U.S. go? That's over $2 trillion per year in additional spending compared to if we spent at the rate of comparable countries. That money goes somewhere. Let's trace where it goes. One of the biggest differences between the U.S. healthcare system and other countries is administrative complexity. The U.S. healthcare system involves hundreds of different insurance companies, thousands of different insurance plans, and incredibly complex billing and coding systems. This creates massive administrative overhead. The multi-payer system. In the U.S., there are over 900 health insurance companies. Each has multiple plans with different coverage rules, different networks of providers, different prior authorization requirements, different billing codes and procedures. A doctor's office that accepts insurance needs staff just to navigate this complexity. Studies estimate that about 8% of total healthcare spending in the U.S. goes to insurance company administrative costs. That's about $1,000 per person just for insurance company overhead. In countries with single-payer or simpler multi-payer systems, this administrative cost is about 2 to 3%. Healthcare provider administrative burden. But it's not just the insurance companies. Healthcare providers, doctors, hospitals, clinics also spend enormous amounts on administration in the U.S. They need staff to verify insurance coverage, submit claims, appeal denials, negotiate with insurance companies, chase down payments, handle billing disputes. Some estimates suggest that for every doctor providing care, there are about 10 administrative staff dealing with insurance and billing. In other countries, that ratio is much lower because the billing system is simpler. A study found that administrative costs consume about 15 to 25% of hospital budgets in the U.S., compared to about 12% in Canada. This difference, multiplied across the entire healthcare system, represents hundreds of billions of dollars per year. Prior authorization. Here's a specific example of administrative burden: prior authorization. Before many treatments, tests, or medications, insurance companies require doctors to submit paperwork proving that the treatment is medically necessary. This process can take hours of staff time per patient. Doctors spend an average of about 14 hours per week on prior authorization paperwork, according to some surveys. That's nearly 2 full work days per week spent on paperwork instead of seeing patients. And this cost gets built into the system, either through higher charges or through the need to hire more administrative staff. Other countries either don't have prior authorization requirements, or they're much simpler because there's one set of rules instead of hundreds of different insurance company policies.
Another major driver of higher U.S. healthcare costs is prescription drug prices. Americans pay significantly more for the same medications than people in other countries. Price comparison examples. A vial of insulin that costs about $35 in Canada or Europe often costs over $300 in the US. The same manufacturer, the same drug, 10 times the price. A cancer medication might cost $10,000 per month in the US, but $3,000 per month in Germany. These aren't small differences. Americans spend about $1,400 per person per year on prescription drugs, compared to about $700 to $900 in other developed countries. Why this happens? In most other developed countries, the government negotiates drug prices directly with pharmaceutical companies. Since the government represents the entire country's market, they have significant negotiating power. If a company wants to sell in that country, they need to agree to reasonable prices. In the US, Medicare, which covers about 65 million people, was prohibited by law from negotiating drug prices until very recently with the Inflation Reduction Act of 2022, which allows limited negotiation for certain drugs. Private insurance companies negotiate individually, but they have less leverage than a national government would. Additionally, pharmaceutical companies spend more on marketing in the US than anywhere else. The US is one of only 2 countries, the other being New Zealand, that allows direct-to-consumer pharmaceutical advertising on television. Those advertising costs, which run into billions of dollars, get factored into drug prices. Patent and exclusivity rules also play a role. The US has longer exclusivity periods for brand-name drugs before generic competition is allowed, which keeps prices high for longer. Healthcare providers in the U.S., doctors, hospitals, specialists, also charge more than their counterparts in other countries, though the reasons are complex. Physician compensation. American doctors earn higher salaries on average than doctors in most other countries. A primary care physician in the U.S. might earn about $230,000 per year on average, while in the UK it might be $120,000, and in Germany about $150,000. Some of this difference relates to the cost of medical education. U.S. doctors often graduate with $200,000 to $500,000 in student loan debt from medical school. In many other countries, medical education is free or low cost, so doctors don't need high salaries to pay off debt. The length and cost of medical training also differs. U.S. doctors spend 4 years in undergraduate, 4 years in medical school, and 3 to 7 years in residency. In some other countries, medical training is shorter or structured differently. Malpractice insurance is also more expensive in the U.S., which factors into what doctors need to charge to cover their overhead. Hospital and facility costs. U.S. hospitals charge significantly more for procedures than hospitals in other countries. A knee replacement might cost $40,000 to $50,000 in the U.S., but $15,000 to $20,000 in comparable European hospitals. An MRI might cost $1,200 in the U.S., but $400 in Canada. Part of this is labor costs, as discussed above. Part is the administrative overhead we talked about earlier. Part is that hospitals need to cover the cost of treating uninsured patients who can't pay, so they charge more to insured patients to make up the difference. This cost shifting creates a cycle where prices keep rising. Facility construction and equipment costs are also higher in the U.S., partially due to regulatory requirements and partially due to market factors. The U.S. is unique among developed countries in having a significant population without health insurance or with inadequate insurance. About 8% of Americans, roughly 27 million people, have no health insurance. Many millions more are underinsured, meaning they have insurance but with such high deductibles or limited coverage that they avoid care because of cost. When uninsured people get sick or injured, they often delay care until conditions become severe and require expensive emergency treatment. Then, they receive care at hospital emergency rooms, which are required by law to treat everyone regardless of ability to pay. Many can't pay the bills, which means hospitals have unpaid costs. Hospitals cover these unpaid costs by charging more to insured patients. This cost shifting adds to the overall expense of the system. In countries with universal coverage, this problem doesn't exist because everyone is covered. Additionally, when people delay preventative care because of cost, treatable conditions become more serious and more expensive. Diabetes management is relatively cheap. Treating diabetic complications like kidney failure or amputations is extremely expensive. Prevention saves money, but prevention requires that people can access and afford routine care. Beyond the specific cost drivers, there are fundamental structural differences in how the U.S. healthcare system operates compared to other countries. Profit motive. The U.S. healthcare system includes many for-profit entities: insurance companies, hospital chains, pharmaceutical companies, medical device manufacturers. These entities have a fiduciary responsibility to shareholders to maximize profit. Other countries have different structures. In the UK, the NHS is entirely government-run and non-profit. In Canada, insurance is non-profit. In Germany, most insurance companies are non-profit. When profit isn't the primary goal, cost control becomes easier. This isn't a judgment about whether profit is good or bad. It's simply noting that a system optimized for profit will produce different results than a system optimized for cost containment and health outcomes. Fee-for-service versus other payment models. The U.S. primarily uses fee-for-service payment, where providers are paid for each service, test, or procedure performed. This creates an incentive to provide more services, whether or not they're all necessary. Many other countries use different payment models. Some use capitation, where providers receive a set amount per patient and are incentivized to keep people healthy rather than provide more treatments. Some use bundled payments or global budgets that encourage efficiency. Price transparency and competition. Healthcare in the U.S. often lacks meaningful price transparency. It's difficult to shop for healthcare or compare prices because prices aren't readily available, vary dramatically between providers, and often aren't known until after treatment when the bill arrives. In other countries, prices are often standardized or tightly regulated, which limits the ability to charge vastly different amounts for the same service. So what does all this mean for you as an individual dealing with the healthcare system? If you have employer-sponsored insurance, your employer is likely paying $10,000 to $25,000 per year for a family plan, with you contributing $3,000 to $8,000 in premiums. Then you have deductibles, often $1,000 to $5,000 before insurance starts covering costs. Then copays and coinsurance for actual care. A family might easily spend $15,000 to $20,000 per year between premiums, deductibles, and out-of-pocket costs for moderate healthcare use. That's money that, in other countries, would either be covered by taxes that are often comparable to or only slightly higher than U.S. taxes, or would cost significantly less. If you're self-employed or buying insurance on the individual market, premiums might be $800 to $2,000 per month for a family, plus the deductibles and other costs mentioned. If you're uninsured, you're one medical emergency away from potentially bankrupting medical debt. Medical bills are the leading cause of personal bankruptcy in the U.S., which is virtually unheard of in other developed countries. The complexity also creates stress and uncertainty. Not knowing what something will cost, whether it will be covered, whether you're in-network, having to fight with insurance companies about claims, this administrative burden falls on individuals in a way it doesn't in simpler systems. America spends about $12,000 per person on healthcare, roughly double what comparable countries spend, due to a combination of administrative complexity, higher drug prices, higher provider costs, the burden of covering the uninsured through cost shifting, and fundamental structural differences in how the system operates. Despite this higher spending, health outcomes are often not better than countries spending half as much. This isn't about assigning blame to any particular group. It's about understanding how a complex system with many interacting parts produces these outcomes. Doctors, insurance companies, pharmaceutical companies, hospitals, patients, they're all operating within a system structure that creates these cost dynamics. Understanding where the money goes helps make sense of why healthcare is so expensive in America and why it operates so differently than healthcare systems in other developed countries. If you found this breakdown helpful, share it with someone trying to understand healthcare costs. Leave a comment about your experiences with healthcare expenses, and subscribe for more videos examining how costs evolved and why systems work the way they do. I'll see you in the next one.